Hi, my name is Dana Morrison, and I am the Senior Director of AETC Programs for the Oregon Primary Care Association. And if you're new to the AETC, AETC stands for the AIDS Education and Training Center. We do get funding from the Health Resources and Services Administration and the state of Oregon to support this work. And of course, whatever I'm presenting is representing my own views and not the views of the state or federal government. I have no financial relationships or commercial interests to disclose, and now to get into the content. So what I'm hoping to do today is to talk to you about what the AETC is doing in Oregon around viral hepatitis vaccination, screening, and treatment, and really think about how we can utilize some of our systems for provider education to really support systems change and practice transformation across the state in relation to kind of syndemic approaches to health system transformation. So what is the Oregon AIDS Education and Training Center? Some of you have seen me over the years, but some of you might be new to who I am and what this program is. And so this is a program that is funded as part of the Ryan White, excuse me, the Ryan White Care Act. And it is a national program that was started during the Reagan administration and really does cover different regions across the nation. We are in the Mountain West AETC, so our headquarters is out of the University of Washington in Seattle. And we have these partnerships in order to really support health system capacity along the HIV/AIDS continuum through the work that we're doing around provider education. So we don't work at the community level, we really do work at that health systems level. Most people also don't realize that we are tied to the National Clinical Consultation Center, as well as the national online curriculums for viral hepatitis, such as the Hep B Online and Hep C Online. If folks call those national hotlines, we actually get a list of callers in the state so that we can follow up and provide ongoing training and education from those one-on-one calls. So we're part of this bigger system. There's people like me in every state, except for the Dakotas. They have to share one person. And then we really work to say, how can we support getting that research into practice as soon as possible? So when new things come out, like directly acting antiretrovirals for Hep C, how are we making sure providers know that as soon as possible rather than having a lag between research and implementation? So we were established in 2002, so we've been a program for a while. We are currently housed at the Oregon Primary Care Association. We've been there for about a year, but we really want to recognize that patients are experiencing multiple aggressions throughout the healthcare process that really limit engagement and access to care. And so we can train providers in all the clinical tools that are available, but unless we're working with linkage and access to care as well, we're not going to really get patients to that amazing care that's out there. And so we work with the Oregon Health Authority to expand our efforts outside of areas of highest prevalence. Our federal funding comes in and says we have to focus on those areas of highest prevalence, whereas the state of Oregon through End HIV Oregon is really thinking about where are the highest disparities in health outcomes related to HIV, and how can we replicate what's happening in our Part A jurisdictions or the Portland metro area into the rest of the state to make sure that no matter where you live in Oregon, you have equal access to high quality healthcare. And really, we provide capacity building assistance along that care continuum. So we like to say we start from prevention and go through viral suppression of HIV, but we also look at other factors that impact people's health. And so really our approach is to put people at the center of their healthcare experience. And so that allows us to do work outside of silos. Even though we have HIV funding, we are able to say, if we know that people who are using substances are at higher risk of HIV, what's going to help that population better access the services, and how do we need to address our systems to really be impactful for community? So this is just giving you a sense of where we currently have a presence. This is from our last annual report. Our fiscal year starts July 1. So this map shows the number of trainings or trainees per county that have received education from the Oregon AIDS Education and Training Center. So you'll see we have a lot of trainings along the I-5 corridor, Central Oregon, but then we also have Umatilla and Malheur counties. And so we also overlap with the high incidence drug trafficking corridors as well, when you think about where we have a presence and where there are health centers or providers to treat folks. So we had trainings in 34 out of 36 counties. Gillum and Sherman counties were the two counties that we did not have a training in. Again, they are not counties that have large, robust health systems for us to provide training to because they have a very low population in the state. And I think it's important to note that 46% of our events really focus on HIV and STI prevention and PrEP, and other co-occurring conditions for folks, and we're not HIV specific as far as care and treatment goes. And so really we try and have a status neutral approach to our work, putting people and whole person health at the center of really being part of ending the HIV epidemic. We did have 550 unique trainees that work in Ryan White Part B jurisdiction. So this is in areas outside of that Portland metro area. So really thinking about how are we increasing the providers in rural Oregon's capacity to better serve their patients and have access to the best possible knowledge and care. So that's that 550 folks are really outside of major metropolitan areas. So here's some examples of our trainings in case you haven't been to one. I just want to let you know, how does Hep C or Hep A and B actually show up in the work that we do as we're doing HIV education. So this is the famous banana split. If you haven't seen it, I'm sorry to have ruined banana splits for you for all time. But really thinking about, if we're thinking about comprehensive STI screening, not thinking about HIV as a silo, but really as part of whole person health. So you have your ice creams in the middle, which are your swabs for GC or gonorrhea and chlamydia. So you have your urine, you have your rectal, you have your pharyngeal swabs, and making sure that people are doing multi-site testing, ideally doing self-swabbing when possible. And then you have your cherries on top, which is your hepatitis serologies, syphilis, and HIV testing as well. Sometimes we also add in the bananas as your HPV vaccination for younger populations under the age of 45. So really thinking about, what does whole person health look like? How are we saying someone's coming in for gonorrhea, chlamydia? How are we making sure that they're getting offered all of the tests that might be relevant, and then making sure that they're linked to appropriate care? When it comes specifically to viral hepatitis, things that we like to make sure that we bring into our primary care conversations is really that hepatitis screening and treatment is part of primary care. I think historically there's been a lot of care that has been sent to specialists. So really making sure primary care folks know what they can offer within their health centers before having to do a referral. So that might be talking about vaccination for hepatitis A and B, or screening and having routine screening for hepatitis B and C based off of the guidelines. And then letting people know that we have treatment available for hepatitis A and B, but we can actually cure hepatitis C, and merely making sure that we're giving access to those directly acting antiretrovirals for the cure of hepatitis C, and making sure that that narrative is out there so that providers know and know how to talk to patients and really use some shared decision making to make sure that patients get the care that they need. I think it's also really important to stress that some patients may need higher level of care based off of cirrhosis and other things. And so some of our trainings really focus on knowing when to refer out of a health center or primary care environment to something higher to make sure that patients get that best possible outcome. So in a snapshot of what we kind of do, I kind of showed you where we are at in the state, but just thinking about the providers that actually attend our trainings. We do have a lot of folks who are in Ryan White funded positions attend our trainings, and as well as HIV care providers. But I think what's important to note is the increasing number of minority serving providers, meaning more than 25% of their panel identify as a racial or ethnic minority that we are training in our program. And then we also have this increased presence across the state in federally qualified health centers. So last year we had trainees from 22 out of 34 health centers in the state. And with our partnership with the Primary Care Association, we really hope to increase that to make sure that all health centers can benefit from what the AETC has to offer. So one of the things, just a kind of quick shout out to the Oregon Primary Care Association, if you're not familiar, it's a coalition of safety net clinics across the state that was founded in 1984. And they really represent federally qualified health centers, which is important to note because it's about 400,000 Oregonians that are receiving care at these health centers and safety net clinics. And that's through about 34 health centers, but it's 270 sites across the state. So by working with OPCA, we were able to reach a broader audience of primary care providers than we were able to reach prior to our partnership, and really thinking about how OPCA is committed to health equity and really navigating state and federal policy to get people the services that they need. And so we joined last year, and we look forward to continued partnership with the Primary Care Association. Our work is not limited to primary care, but it seems like that is an area that's been much in need of growth, and this is a great opportunity for us to align some of our work for patients, especially outside of the metro area. One of the things we do that when I was talking with Lauren and Anne about this is we do something called practice transformation. It's a type of intervention funded by HRSA to really think about the systems of care. So there's the clinical education, but there's really this broader systems of care. And so this is an example. You don't need to read it. It's just to kind of show you how we work. And by we, it's primarily our senior manager of practice transformation, Raina Appenzeller, really works hard to identify who the stakeholders are in a community, to identify who's doing what work, really thinking about how we leverage systems and how we build workflows to streamline care, but also make sure that there's continuity between staff transitions and people know who does what. So this is a diagram that came out of work in Jackson County, really thinking about who are the community partners, who needs to be at the table. And then when after doing that, coming up with swim lanes of what happens when there's a new diagnosis, what happens if there's a hepatitis C diagnosis, or if a person needs PrEP, and what are the social determinant healths, or what are the other partners in our community that can really ask that person or that patient at the center of their care, what do they need to feel successful? What are their health goals or life goals that might need to be addressed before some of those clinical things happen? Not everybody wants to start treatment right away. So what other supports do they need, such as housing, and how do we connect? So this is the start of a process. It usually starts with a block diagram, kind of gets into swim lanes, and then really there are thinking about how do things connect and mapping that out so folks can really think about what quality improvement supports can the AETC offer, following special projects of national significance as well as other toolkits. And then we can work to implement those systems level changes to really have a sustainable impact on access to care. Other ways that folks can just access our provider education, if you haven't been to our website, this is a website page that we have focused on Syndemic, specifically looking at HIV, Hep C, and substance use disorder. So you'll see Dr. Andy Seaman in a video he has down there. These are a series of videos we did across the state. When we were all at home with COVID, during the COVID pandemic, we were doing videos to really increase access to education, but I encourage you to look at them because a lot of what Andy talks about and what we have on this page are resources to really shift the mindset of healthcare to more of a harm reduction mindset. So really thinking about where patients are at in their own journey and moving away from provider goals to patient goals, and really thinking about how we can provide the best possible care, and that treatment for substance use disorder is part of primary care, and really we need to make sure that there's widespread access. Another thing that we offer at the AETC is for providers that you might have in your region or jurisdiction that are newly prescribing HIV, PrEP, HIV meds, PrEP, or even Hep C. They can reach out to our clinical faculty and schedule directly onto their Outlook calendars to have a 15 or 30-minute check-in to talk about a case or something that's coming up or any educational pieces that they might have. And so here's an example of Chris Evans. He's the medical director of the Oregon AETC. You can scan the QR code, you can go to our website, but you can schedule with him directly for provider-to-provider education so that folks who maybe don't see lots of cases of HIV or Hep C or syphilis have someone that they can reach out to in real time to really get that feedback. Hey, I learned this thing in one of your lectures. Now I'm trying to apply it. Here's where I got stumped. That sort of conversation can be really helpful in building provider confidence to prescribe in their region and not make referrals up to Portland for care, which is not necessarily accessible for many Oregonians. So with that, I'm going to end. I kind of had 15 minutes to go really fast to talk about the AETC, what we do, and kind of how we tie viral hepatitis into the work. But really, I think it's important that we have ongoing conversations and really think about what does whole person health mean? What does that mean to the person that we are working with? And how do we work better as a system to serve that human along their journey? So with that, I'm going to end, and I think we're going to go into some questions.